I'd like to introduce the first speaker, who is Tian Wang, on artificial intelligence for diabetic retinopathy screening.
Thanks very much for the chance to talk about this topic. These are my financial disclosures. In particular, I have some IP and equity owner on a startup company on AI. I think we all know here that diabetic retinopathy screening is widely recommended. These shows the numbers of people with diabetes and the number of people that needs diabetic retinopathy screening, which is about 400 million people globally, and of course it's a problem that many of us struggle with. There are few national diabetic retinopathy screening programs, this one in UK. In the US, even though it's been suggested to have a national diabetic retinopathy screening program, I think the burden as well as the resources to do it has been suggested to be very difficult, and in some areas, automatic diabetic retinopathy screening system, in theory, could replace or help with this program. Of course, a few years ago, Google started thinking about diabetic retinopathy and designing the AI deep learning system for diabetic retinopathy. But when you look at AI in medicine, there's been a lot of discussion about this, and some of it has been a lot of hype. But when you look at the historical records of AI and machine learning, 1970s, it was really discussed. 1987, a lot of decades, a lot of discussion about this, but yet there's been still very difficult in moving AI into clinical medicine. AI, in effect, has many branches. It was started in the 1950s. Machine learning was a separate branch that flourished in the 1980s. And then deep learning, which is the latest, most powerful program, started in about 2010. And the recent interest in AI really stems from deep learning, which has really revolutionized the field. The reason for that is that for machine learning, there is a peak in performance with the amount of data that's given, but for deep learning, it seems to improve with increasing amount of data. And therefore, deep learning has been suggested to go beyond the human performance level with error rates of less than 5%, which is kind of the human performance levels. It's been now used in many different fields, for example, dermatology, and in pathology, radiology, and other fields. For deep learning in ophthalmology, diabetic retinopathy screening fulfills a lot of the possible progress made in this field. There's a clearly defined gap. It's tested in real-world studies. There's experience in regulatory approval, and is now really ready for clinical use. There are, of course, other deep learning technologies. Some of you heard some of these in the morning, which I will not talk about. Let's look at diabetic retinopathy screening. The traditional diabetic retinopathy software is based on pattern recognition, looking at where microaneurysms, heart exudates are. The general performance and accuracy has been in the 80 to 85% range. The difference with AI and deep learning is the following. For pattern recognition, you need to annotate where the lesions are, and the program looks and says whether there's diabetic retinopathy. For deep learning, you just need to give the machine the images, and you say whether there's diabetic retinopathy or not, and the program comes up with its own algorithms to look at that. So, of course, there's many different programs. One of the earlier deep learning ones that made a lot of impact was Google's one that's by Zhongshan et al., showing a very high performance, and then subsequently tested in 2 populations in Thailand and India. There's the IDX algorithm with Mike Abramoff, and it's also been tested in Netherlands with showing high sensitivity and specificity. The Singapore's program was also shown to have good correlation in 10 external data sets, and recently we have also validated this in Zambia, diabetic retinopathy screening population, which the machine has never seen those images before. There are many programs in China, and this is just one of them, showing again very high AUC curves. And there's also one that Jennifer Lim and others have looked at, which is the EyeART algorithm, and also shows extremely good AUC sensitivity. And this kind of summarizes those recent programs showing you high performance, both sensitivity and specificity, particularly for referral diabetic retinopathy. It is important to see where does such an AI algorithm fit for diabetic retinopathy screening. So if you look at this and you think that it can either be a replacement test or a triage test. So what are we trying to replace, or what are we trying to triage? So if you think that doctors or optometrists need to do diabetic retinopathy screening, then in one particular possibility is that a Google program or some of the other programs may replace that entire screening possibility. Another would be to triage that, and for those that are positive, you still need an optometrist or a doctor or specialist to look at those kind of situation. So what's the path forward for diabetic retinopathy screening? What do we need to do? I think it's important to have good data. The saying goes that garbage in, garbage out. Good gold standards is important. There are lots of technical issues still, for example, the black box problem. There are also non-technical issues about patients, physicians, regulations, integrations into EMR, IT systems, the financials, who's going to pay for it, how much can you pay for it. And then there needs to be more on guidelines, standards, reporting, and so on and so forth. If you look at what we are really needing, it's both quantity and quality of the input data is quite important. The way to annotate the data will give better algorithms, and I think that at the moment this is still very limited. Then the technical issues of explainability and the black box. So, for example, the Google's program suggests that if you want to explain age, blood pressure, smoking, and HbA1c, it picks up blood vessels. But gender, BMI, and diastolic blood pressure, it can't tell you exactly why it can predict it so well. So, it can't explain that program. Then there's lots of non-technical issues, with public, patients, and physicians' acceptance of AI, and in radiology, for example, computer-aided diagnosis still finds it difficult to be implemented in mammography and radiology. So I think that's something to be looking at. So if you look at disruptive technology, it goes through a peak of what we call inflated expectation, and then after that, there is things that's progress, and gene therapy, which is discussed at this AAO, has made that kind of slow progress now. I think AI and deep learning is going up that peak, and I hope that it doesn't fall into the depths, essentially. So in conclusion, let me say that AI and deep learning is an exciting technology that disrupts medicine and impact on eye care. For certain narrow specific tasks, like diabetic retinopathy screening, I think it has potential. The key challenge is to really address both technical and non-technical issues. Thanks very much.